So this was our slide to indicate transitioning speakers, but it really is talking about transition of to newborn life, and that's mostly what I'm going to be focusing on. As Bruce has mentioned, in fetal circulation, there's a large amount of the blood that's in the cord and placental compartment, as we describe it. In the preterm baby, that's a larger proportionate amount. So before 37 weeks, that comprises about 50% of all of the blood flow is in the placenta and cord. And as you get closer to full term, that amount drops off to, as Bruce said, 30 to 40%. So a significant amount of blood is in the placenta and cord at any one time. As Bruce talked about, what happens at birth. Well, without any intervention, we know that a significant amount of that blood flows through from the cord and placenta, or through the cord from the placenta to the newborn. When we clamp the cord before that's happened, we have a damming effect, so the blood stays back in the placenta and doesn't flow through to the baby. We've known this actually for quite a long time. There's a lot of research that comes out of the 60s and 70s that looked at the sort of physiological side of things. And one of the early studies from 1969 was published in The Lancet, looked at the volume of blood that was transfused, and found that compared to clamping the cord within 5 seconds, when the cord was clamped after 3 minutes, or at around about 3 minutes, there was a 32% difference in the blood volumes in babies. And that they also found that about more than half of that occurred in the first minute following birth. So a fairly rapid transfusion of that blood to the baby. They also found from those earlier studies that the placental circuit is never completely emptied. In other words, there will always be some residual blood that stays in the placenta, and that after about 3 minutes, there's no really additional transfusion effect. And that really goes back to what Bruce was saying with the closing down of the umbilical arteries, that sort of stops that flow from happening after a period of time. A recent study looked at this phenomenon again, and this study is I think quite an elegant little study. They studied 26 babies. 13 of them were born by cesarean section, and 13 were born vaginally. And when the babies were born, they put them into warmed blankets on a scale. So the scale was balanced for the blankets. They took the baby at birth with the cord intact and put the baby on the scale. And what you can see here is the difference in weight from the time the baby was born to 2 to 3 minutes after the birth. So this is the 4-minute mark, and you can see that in fact in this is an example from one baby. This baby went from being somewhere around about 3420 grams up to almost 3600 grams in that period of time. So quite a significant increase in weight. And they found that this weight change happened with when they looked at all babies, the mean difference in weight was 116 grams. They found that the effect happened when they looked at both cesarean and vaginal births. They found that when the baby was placed at the level of the bed and above the bed, they still got an effect. And when a uterotonic was given. So a uterotonic is given after birth to help manage the bleeding for the mother, and when the uterotonics were given, they found the effect occurred equally as when it was not given. When we looked at what this means in terms of the newborn, 1 ml of blood weighs approximately 1.05 grams. So the mean placental transfusion was about 110 mils. And that translates to about 32 mils per kilogram of birth weight. So in total, if you consider that the blood volume for a newborn is about 80 mils per kilogram, you're looking at about a 40% difference between the baby with a clamp, where a clamp would be placed early on, and when the clamp is placed after that transfusion effect has been allowed to occur. So I think you would agree that's a fairly significant amount. When we go back to looking at some of the earlier studies, we see that following birth, the circulation system in babies that were clamped late adjusts fairly rapidly to the extrauterine life. So when they compared the babies late clamped to early, they found that there was initially a higher blood pressure, which dropped off over that first 4-hour period. They saw a fall in the total blood volume and increased plasma transudation accounting for that, which resulted in increased urine output, as we've mentioned, the decrease in the blood pressure, and a higher hematocrit at the time in the early days. This slide just shows the blood pressure. Another study reporting on blood pressure showing that in the early babies clamped early, the blood pressure in the initial few minutes was higher, and after 4 hours that had decreased to being about the same as the babies that were clamped early. So all of these are the kinds of physiological changes that Bruce was describing that we would anticipate seeing with that transfusion happening. So we were interested in looking a little bit at what happens in practice, and what are people doing in terms of cord clamping. In the preterm population, just for those of you who aren't clinicians, typically in the recent years, when babies are born, the clamp goes on very quickly. I was surprised to hear people talking about the clamp going on within 5 seconds, because as a midwife, I have to assure you, I am not dexterous enough to get a clamp on there in 5 seconds. But when I talked to some of my obstetrical colleagues, they said very often there's another care provider who in fact is waiting with the clamp in hand, a clinical clerk or a resident maybe standing by with the clamp ready to apply it, and so the clamp really does go on very quickly, often after the baby is born. And that's just really a result probably of us having very, very easy to use clamps. I mean, if you think back 100 years, we tied the clamp off with string or with a little sterilized tie. And that takes a bit of time to actually get the tie and take it and put it in place. But once you have a metal locking forceps, it's very easy. Pick it up, put it on, it's done. Then you can clamp it, hand the baby off, and move on with the rest of the maternal care. So I think it's a practice that really came into being really because we could. Not because we thought about it, not because we said, oh, is this a good idea or not, but really just because we could. So in the preterm population, when they began to look at what happens when we in fact delay the clamping, the findings were fairly significant. There's a Cochrane review that reports on preterm babies and timing of cord clamping. 15 studies were included, and that involved 738 babies. And again, for those of you who aren't familiar with the idea of systematic reviews and meta-analyses, that's really a study that takes all of the studies that have been done to date by systematically looking at the literature and finding them, and then takes the results from those collected studies and compiles those results to come up with an effect estimate. So these studies defined delayed cord clamping as longer than 30 seconds, and the longest time they found was 120 seconds. They looked at a large number of outcomes that are significant for preterm babies, and what they found was that when you delayed cord clamping, remember by 30 seconds to 120 seconds, there was a higher 4-hour hematocrit in the babies. They found that they needed fewer transfusions for anemia, which is a common problem in the preterm babies. And they found that they had fewer cases of intraventricular hemorrhage and of necrotizing enterocolitis. So for those of you who aren't in the practicing fields, just to know, those are two really quite onerous outcomes that plague particularly the very preterm populations. So again, they found about a 50% decrease in those outcomes, which is a very significant change. So the implications for practice in the preterm are that clamping, delaying clamping by 30 seconds to 120 seconds is better than clamping earlier than that, and is associated with a decrease in rates of significant complications, and including the need for transfusion. So the guidelines for the preterm population actually changed in the scheme of things fairly early on. When those publications in the Cochrane Review came out, the change in practice, I think, began to happen fairly quickly, and the guidelines changed fairly quickly. But after the Cochrane Review for preterm was out, we had no review for the term population, which prompted myself and a colleague to do a systematic review. This was completed and published in JAMA in 2007. And we looked at what happens in the term population with delayed cord clamping. So we included studies of babies that were more than 37 weeks gestation, which is the cut point for preterm and term. We included 15 controlled trials. So we included both randomized and non-randomized controlled trials because there were, in fact, very few randomized trials at that time. And we looked, our definition was delayed greater than 2 minutes to be included in the delayed group. And early was defined as immediately, although there was quite some variation in the studies, including studies where early was up to 1 minute. Again, we looked at a large number of outcomes relevant to the term population, many of them looking at outcomes associated with iron status and hematological outcomes. And what we found was that the blood volume at 2 to 4 hours was increased with a weighted mean difference of 9 mils per kilogram. We saw that the risk of anemia at 2 to 3 months was decreased by 50%. So again, for those of you who aren't familiar with meta-analyses, what you'll see is this forest plot, which lists the studies here that were included in this particular analysis. This gives you the event rates in the control group or in the two groups, and then the estimate for each of the studies, and then the combined estimate, and then tells you whether, as in this case, your estimate is clear of your null value, it's suggesting that in fact it's a statistically significant outcome. And in this case, then you look at your, to see whether you think it's a clinically important outcome, and I would argue a 50% decrease is clinically important. We also found that the ferritin levels were improved at the 3-month mark, both looking at babies who had ferritins less than 50 micrograms and at the weighted mean differences in ferritin levels. So our findings overall showed that when you delayed cord clamping by at least 2 minutes, you improved both the short and long-term hematological and iron status for babies. We saw no significant impact on the bilirubin plasma viscosity in the first week. We did see some increases in the reported rates of polycythemia, which is the concentration of red blood cells, although no babies needed treatment for that. And we saw no increase in the rates of neonatal intensive care unit admissions or in the rates of phototherapy. When this study was published, it was the editor's choice, and the editorial report that went along with it suggested that although the findings were interesting, that they didn't feel that there was enough evidence at this point to change practice. So that was an interesting comment, I thought, because our conclusions were in fact that we should delay cord clamping by at least 2 minutes in the term infant where there were no contraindications, because we saw a benefit for the infants out as far as 6 months of age. After our study was, so we did conclude that we should delay clamping. After our study was published, there was a Cochrane review done, and that study included only randomized control trials. And they found findings very similar to ours, but they indicated that there was an increased rate of hyperbilirubinemia, so increased number of babies with jaundice that needed treating. And they were therefore advising caution and suggesting that there was some ambivalence as to whether we should clamp early and avoid the jaundice, or clamp late and enhance the baby's iron stores and so on. Subsequent to our study being done, or the reviews being done, another study came out. This one was done in Sweden and included 400 term babies there, and looked at delayed and early clamping. That study they indicated was done because many of the studies that we had included in our systematic review were done in under-resourced countries, and they felt that it was important to replicate the findings in a country with high resources. And essentially their study found the same findings as we reported in the JAMA report. Improved hematological study findings out as far as 4 months of age, with no increases in the rates of complications of hyperbilirubinemia and polycythemia. At this point, if we look at what's happening in the guidelines, it's been fairly, taken a bit of time for those findings to sort of move into place. But the Society of Obstetricians and Gynecologists now recommends a delay of 2 minutes for term babies. They don't have a specific guideline for cord clamping. It's sort of buried in about 3 different places. In one of the guidelines, it talks about management of third stage of labor. There's a guideline that says that you should delay until, that they support the international guidelines from the Federation of Gynecologists and Obstetricians internationally, and that recommendation is that you should delay until the cord has stopped pulsing. And in another part of their guidelines, they talk about a 2-minute delay. They do recommend delaying for preterm babies as well, 30 seconds to 180. The new National Neonatal Resuscitation Program from 2010 now advises that cord clamping should be delayed for at least 1 minute for healthy term babies, and that's been a big change there. And they are also recommending for preterms that there be a delay. And in Ontario, the Provincial Provincial Council on Maternal Child Health has a directive for clinicians indicating that clamping should be delayed. So we're beginning to see guidelines change, which is encouraging from my perspective. So we were interested in looking at what happens in practice, and going back a few years now to 2006 and 2007, we did a survey of providers across Canada, and we asked them, what do you do when babies are born for term pregnancies and for preterm pregnancies? We had a response from 353 participants, 187 midwives, and 166 physicians. We asked them if they made a conscious decision about the timing of cord clamping. At that point, 40% said no and 60% said yes. And of those saying yes, 80% were midwives and just under 40% were physicians. So many people at that point still not really considering whether they should, or when they should be clamping. And when we asked them when they did clamp the cord, we see that about 35% indicated that they clamped within 30 seconds, and about just under 50% indicated that they clamped at a minute or later. When we looked at this outcome by clinician group, we see that the majority of obstetricians were clamping within 30 seconds, and that the majority of midwives were indicated that they were clamping at 60 seconds or longer. We then undertook to do an observational study So because we wanted to know, the survey was obviously asking people what they think they do. So we were interested in asking people what they were, or seeing what they were actually doing. So we did a small observational study when I was in Vancouver at the Women and Children's Hospital there. And that study we had someone, a research assistant, go into the delivery room to ask permission and got consent and so on, and went into the delivery room with a stopwatch and timed the time from the moment the baby was born to the umbilicus till the time the clamp was placed. And in that study we saw that the range of time clamping was 2 seconds, which amazes me, but apparently is possible, to 13 minutes and 41 seconds. So clearly somebody waiting for the cessation of pulsing cord. They found, and the median, it was 13 seconds, which I think is really interesting. It's, again, falling well within the 2-minute mark. Only 10 cords, in fact, were clamped out of 95 at 2 minutes or longer. And when we looked at this for all care providers, you could see the 50% were clamping within 15 seconds, and then a small number, just around about 10% at each of the other time points. And when we looked at it by care provider group, you can see that the majority of obstetricians were clamping within 15 seconds, but the number of midwives who were clamping within 15 seconds was also quite high, and those clampings after 60 seconds was not as high as might have been anticipated given the survey results. So we found that for all care providers, the majority clamped within 2 minutes. The most common interval was at less than 15 seconds, and that we had inconsistencies between our survey findings and our actual time findings. We've just very recently, in the fall of this year, done a survey of obstetricians again, and I don't have those results here for you today, but I think we have seen a shift in practice, so that's encouraging, but we certainly don't have the majority of physicians waiting for 2 minutes at this point. From the studies that we did, we feel that the actual time of clamping may be shorter than is estimated, and one of the physicians who I knew from BC Women's said to me that she really hoped we'd carry on with the research on cord clamping. She said, you know, I knew what your study was about and I knew what the research said, so when I was asked if someone could observe, I took my time, and I really waited. And when afterwards she said, I hope you don't mind, but I asked your research assistant if she could tell me how long it took before I clamped the cord. And she said, I was astounded to find it was like 20 seconds. She said, I thought for sure that I had really let that baby, have its transfusion effect. So I think that especially in the moments after birth, we're not probably very good at estimating long periods of time. Time goes by very slowly in those moments. It may be really useful for us to have a regularly recorded timing of the cord clamping on our delivery room records. Thank you. Because I think if we start doing that, it will become reinforced, and people will begin to recognize that they are in fact clamping earlier than they think they are. It's also been suggested that you can use the warmer in the room to in fact set the warmer, which you set anyway or can set for time doing your APGARs, for example, and use that to actually time the time to clamping. It may be also helpful for us if we had a national guideline that focused specifically on cord clamping as opposed to on having it buried in several different places, because I think oftentimes people aren't aware of what the recommendations are. One of the other things that we should address at this in this conversation is stem cell collection, and as Bruce has mentioned, stem cells are abundant in not only in the Wharton's jelly but also in the placental and in the fetal blood. And stem cells are collected, and parents are offered the opportunity to collect stem cells for the future use of their offspring, either this baby or other children they might have. So for a fee, they can have cord stem cells banked. And the question that really comes up is it more useful to collect stem cells and bank them, or give them to the baby now? I think it's an interesting discussion. We certainly know that the number of people who have banked stem cells and then gone on to use them for their own infants is a very, very small number. It's infinitesimally small. So I think that if we're looking at stem cell collection in any way, using a public bank would make much more sense than individual banking, although that's not available in very many provinces. But the whole question of whether these stem cells should be collected, I think, is a good one. There are a few articles or commentaries looking at that, some quite excellent ones, looking at the ethical considerations of blood banking, really asking whose stem cells are they anyway. I just wanted to close off with a quote for you. This is a quote that says, "Another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left until the child has not only repeatedly breathed, but until all pulsations in the cord cease." And I think the interesting thing about that is that it's from the 1800s. So this is all not a very new discussion that we're having today. Thanks. So I think we have time for questions.